I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, and welcome to the May 2017 edition of the PRS Journal Club podcast. I'm Chad Purnell, PRS Resident Ambassador from Northwestern, and I'm joined by my co-ambassadors Jordan Frey from NYU and Shuja Shafqat from Lehigh Valley. Today we have the honor of being joined by Dr. Don Mackay, Professor and Chief of Plastic Surgery at Penn State. Thank you very much, Dr. Mackay, for joining us for this PRS Journal Club podcast.
You're most welcome. Thank you.
The article we'll be discussing today is Primary Septal Cartilage Graft for the Unilateral Cleft Rhinoplasty by authors Liu, Yao, Lin, Chang, and Chen from the Changgung Memorial Hospital in Taiwan. As a quick reminder, all of the articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. So, just as a quick overview of this article, correction of the cleft nasal deformity is one of the most challenging aspects of pediatric plastic surgery, and these authors from Changgung Memorial have been proponents of primary cleft rhinoplasty and a rather aggressive primary cleft rhinoplasty for quite some time. And in this article, they're presenting their most updated technique. Previously, they published their technique involving an overcorrection on the cleft side nostril height without any grafting, and they noted that still didn't completely correct the deformity long term, and so this is their updated technique, which utilizes a primary septal cartilage graft. Overall, this is a retrospective review of 59 patients from 2007 to 2012 utilizing their current unilateral cleft repair technique at Changgung Memorial. A single surgeon performed all of the repairs. Their technique first starts with every patient undergoing nasoalveolar molding, which I think is important, and then they perform their repair, which is a modified rotation advancement type repair, and they also perform an anterior palatoplasty at the same time, and they do this with a septal and vomer mucoperichondrial flap. And so after they've taken this flap to repair the primary palate, then they harvest the anterior caudal nasal septum. And they say that their harvest size is about 0.5 centimeters by 2 centimeters. And then what they're doing is they're performing a Tajima type incision on the cleft side, and they're placing that septal cartilage graft as an alar rim graft through that incision. And so after they've performed this repair, then all patients undergo 6 months of nasal stenting. For all of the patients in the article, they all have at least 3 years of follow-up, and the authors are making multiple measurements of the nostril and nasal sizes at multiple time points. And so they compared these with a historical cohort of patients who underwent the previous technique without cartilage grafting. They also had 2 surgeons and 3 laypersons scoring the pictures of the patients on a 5-point Likert scale for symmetry of the nose. So all the patients in the study were unilateral complete clefts, and there were 39 graft patients and 59 non-graft patients. Whenever they looked at their measurements, nostril and nasal measurements, they found several significant differences between the two groups. So they noted in the graft group, the nostril height was higher, the nostril was significantly more rounded, and the dome height was also higher. They also noted that the nasolabial angle and the tip projection ratio weren't different between the two groups, which the authors interpreted as there wasn't really an effect on nasal growth from harvesting this cartilage. They also looked at several measures of asymmetry of the nostrils, and they noted that more of the graft patients had higher levels of symmetry with the non-cleft side with respect to the nostril height. Whenever both the surgeons and lay people scored the nasal symmetry, both groups scored the nasal symmetry higher in the graft group as well. So in their discussion, the authors note that even with their prior technique of primary rhinoplasty, which was rather aggressive by most people's standards, the cleft side ala tends to collapse by about 20% with time. So what they note with this new technique is that the septal cartilage graft does appear to improve the nostril height and symmetry, and there don't appear to be any effects on growth. However, they're also quick to note that they're going to continue to follow these patients longitudinally because the question is incompletely answered as these patients haven't been followed to skeletal maturity yet. They also noted that their technique may actually raise the dome too high. They actually may overcorrect too much on the cleft side, which is the trade-off for a better nostril shape. So you're trading a higher dome for an improved nostril symmetry. They also note, and they show pictures from a patient who's had this technique and with 7 years of follow-up, and they note that he has maintained his result for that period of time. overall, I found this article very intriguing. Whenever I was initially learning about cleft rhinoplasty, the initial things that I learned were that you shouldn't touch the septum at all because there's concerns for growth of the nose. However, as I read more, and actually as I've seen some of my mentors change their techniques, I've seen more authors performing a primary septoplasty. And now these authors really have gone as aggressive as I've seen, where they're actually harvesting septal cartilage for grafting at the time of primary rhinoplasty. I have to admit, their results do seem impressive, and the pictures that they show have great symmetry, and their nostril shape is some of the best I've seen for any article. I think this article really shows the wide range of what's being done out there and how aggressive some of these authors are at performing a primary rhinoplasty compared to the old adage of that we should leave the nose alone in cleft patients. So I'm really interested to see more long-term follow-up results from this group, because really what's going to sell me on this technique is long-term follow-up at the age of skeletal maturity, showing that these patients don't have any growth restriction because of this technique. With that, Dr. Mackay, I wanted to turn it over to you. What did you think of this article?
I thought it was excellent. These guys really, in many respects, have defined the field of primary rhinoplasties. And you're absolutely right. They seem to have become more aggressive and more extensive and added sequentially to what it is that they're doing. The fact that they're now doing a primary septoplasty is quite illuminating. I was asked to do an MOC article on the cleft nose a couple of years ago, and I think it was published in 2010. And I learned a tremendous amount, and I learned at that time that in fact there was good data out there for doing a primary septoplasty. There was a paper that was published out of Poland with a 14-year follow-up of patients that had had a primary septoplasty with no effect on facial growth, no effect on nasal growth, and at 14 years better surgical and nasal outcomes than if they had the primary septoplasty. So the Changang group have done things sequentially. They've shown that you get improved appearance with the nose once you do NAM. They then showed that if you splint the nose, you get further improvement. And if you splint it for 6 months, which I defy any American surgeon to get their kids to wear a splint for 6 months. We certainly haven't managed to do it here. The families and the kids won't tolerate it. They also showed that if you overcorrect, that improves it. And it's these combinations that have given a better long-term result. Now they're adding a septoplasty and taking a piece of cartilage and putting that on top of the dome on the other side. It's kind of difficult to separate all of that out. But clearly, when you look at their results, it's hard to argue with them. I think there are a couple of other things that are important to note. One is that this same group of authors showed that with extensive NAM and overcorrecting, that you get a significant relapse within the first year. And that didn't change much up till the third year. So that the fact that they're following out for 3 years is based on some of their previous work. I'm not sure that many of us do as extensive. I don't routinely do the Tajima approach. I'm not sure that I would do this cartilage graft now, although I'm going to be tempted to. As I say, I can't get my patients or the families to agree that the patients are going to be splintered for 6 months. That splinting, incidentally, also carries an inherent risk of ulceration, and Dr. Losi can talk to you about a couple of complications that they had with that long term. But I think putting all of this together, they make a really strong argument for what they're doing.
I agree. It's hard to argue with their results. I guess that helps me transition to a question I wanted to ask you. So if you're not doing quite as aggressive of a rhinoplasty as them, and you're not doing the Tajima approach, what do you do during your primary cleft rhinoplasty?
This is for unilaterals. I do I call it a variant of a straight line closure. I believe that you want to position the philtral column where it lies normally, which in most patients, in fact, it takes its origin from the footplate of the lower lateral cartilage. So I use that incision. I extensively dissect over the lower lateral from my medial incision and the lateral incision. I do fairly wide septal dissection on both sides, freeing it up from mucoperichondrium on both sides, free it from the abnormally positioned nasal spine. I will use a tacking suture to put the septum, just tack it to some periosteum on the alveolus if it doesn't lie there normally. I do close off the nasal floor with a flap from both septum on the non-cleft side, and it'll be skin mucosa going up to the inferior turbinate on the cleft side. So I close off the nasal floor there, and also laterally will dissect over the lower lateral cartilage. So fairly extensive dissection, both from medial and lateral. And then I, in most cases, will do Mackay type sutures, except they're tied intranasally, and I'll use PDS so it holds it up for enough length of time for it to remold. I rely a lot on the positioning of the nostril base, so we don't do any NAM at this stage. So the positioning of the nostril base is really important, and getting that muscle all the way across underneath the nostril sill helps position and shape the nose and the nostril. And then I'll use the Mackay sutures. I'm usually using something like 5/0 monocrol with the knots tied intranasally to shape it. Now, if I can't get a decent shape with that, then I will go to the Tajima and try and get some of the smaller sutures so that you're pulling that dome up, trying to overcorrect it and towards the cleft side. But it's tough. I can't get my patients to wear the splints afterwards.
And we can't either. We try to recommend it for 6 months. I have yet to see a patient who's made it that long.
He's dealing with a different population. I think they listen to the parents.
Yeah, I think so. You actually are performing a pretty aggressive septoplasty, so you're not far from the author's technique, just minus the Tajima and the cartilage grafting, so you don't have long to go. Shuja, what did you think of this article?
I thought it was a great article. The pictures speak for themselves. I mean, the results and their long-term outcomes are very impressive in terms of nostril symmetry, and you can even see how initially there was some overcorrection that does settle out over time, and they actually have very good pictures, so I thought that was very impressive. Clearly, the outcomes we're looking at are really long-term. So, Dr. Mackay, I'd be interested to see what your concerns are for this technique long-term, especially in the cartilage graft portion, since you don't do that, but they did that in this paper. Is it warping, lack of support over time, changes in the cartilage, and clearly growth disturbances has not been shown, but do you have any concerns about that in taking the cartilage graft itself?
You know, I think one of the things that we've learned is that you can do a lot more than we ever thought possible or necessary and still have normal growth. Does it hold up to the point that you don't subsequently need to do anything? I don't think that that's true. I think that the majority of these patients are still going to have a final rhinoplasty, and in my case, many of them will have something done at an intermediate stage. There's no doubt the patients who've had more extensive surgery, the subsequent rhinoplasties are much more difficult, even if you're doing an open rhinoplasty. There's a tremendous amount of scar. That dissection takes a much longer time. But if you're prepared to be patient and do that, there's no reason why you can't still get a decent result. I think the benefit that you gain outweighs the subsequent difficult dissection on your subsequent rhinoplasty. And I think that the fact that you've done something and are prepared to do some of the intermediate steps gives your patient's psyche a huge boost. We've got, I believe, this is anecdotal, that we have far happier patients with us doing something and trying to make these noses look better than what we used to do, and that is to say, you know, I'm not touching the nose. And this is what I was taught. You don't touch the nose. You wait until they finish growing, and then you do the rhinoplasty. Well, that condemned a whole lot of these kids. You can imagine going to middle school. That's miserable enough. And now you look a little bit different, and you got a nose that's plastered to the side of your face. There, it's awful.
My other question was kind of what you mentioned already, is anybody who's done any secondary rhinoplasty knows that it's extremely challenging to do in dissection and all of that. So You mentioned that you still feel that you can get a good result on the secondary rhinoplasty or the completion rhinoplasty at the time of growth. Is there anything different that you would do with your technique in your final rhinoplasty, or anything that you think that people should look out for if they're doing these completion rhinoplasty cases on patients who have had cartilage grafting?
So I think you've got to be particularly careful with your dissection. There is definitely more scar tissue. You may need to exaggerate the grafts that you put in place to get a symmetrical result. Because of the scarring, you've got to, again, going back to the care that you take in the dissection, blood supply can become an issue. But apart from that, I still believe that the more aggressive approach is warranted. You know, in terms of long-term outcomes, I think that this field, as much as anything, suffers from the fact that we don't have long-term studies that we all agree on. So I'm putting in a plug here for the Eurocleft and the Americleft groups, where if we had buy-in from everybody, we could compare what we're doing here or what Chad's doing at Lurie or you guys at NYU over the long term. And we need to agree on a set of criteria that we'll use, some validated tools for outcomes, and then compare our results. You start understanding where all these different factors play in. And I think we'd be doing our patients a great service. You know, we all inherently believe that NAM is the way to go. Well, you know, for 3/4 of the world's population with patients with clefts, that's just not going to happen. So what's out there that works well short of NAM? Those are the kind of questions that I think are important to answer. I would even query that, show me that the patient that we take right at the beginning, and once they completed all their treatment, has NAM made that much of a difference? Can you show that that investment in time and effort and cost in many cases is worth it? It's a field that suffers because of it. I'm going to put myself out there a bit. I think that in many cases, we do need to be more prepared to do evidence-based examination of all of this stuff and truly compare what we're doing with things that we'll agree on. Otherwise, it's like someone standing up on a stage saying, this is what I do, this is how many I've done, aren't I great? Well, that's not science.
Definitely, and I've heard you say that multiple times before, so that's great. Good points. Jordan, what did you think about this article?
I really enjoyed reading this article. I thought it was interesting to learn about their technique. I was likewise kind of interested and surprised by how aggressive they were. But I think that's what's so great about cleft surgery and really all plastic surgery is we're continually trying to improve our results and come up with better techniques and better ways to solve these tough problems. And I couldn't agree more with your point, Dr. Mackay, about the need for long-term, multiple center data to really establish what best practices are and how we can best treat these patients. I think we've mentioned the horizons or challenges in cleft lip surgery that need to be surmounted, but as I think a theme of this paper was kind of the progression from, as we've said, leave the nose alone to becoming more aggressive and saying, well, I think we can do this, and I think this can give us good results when we do it well and we do it right. What's another area, or what's the next horizon or the next challenge that you see that needs to be solved in cleft lip surgery or cleft surgery or anything like that?
I think if we can take the lessons from what these guys have done, it's going to be difficult in many places unless you've got the same quality of the NAM preparation to compare from one center to another. One of the things that, again, in clefts that is hardly ever spoken about is the severity of the initial cleft. Generally, all these patients are lumped together. So if you've got a complete unilateral, well, we all know that not all complete unilaterals are the same. We all can show patients who've had no NAM and a straightforward repair. The nose is going to be in a reasonable position to start off with, and they look great, and the results hold up forever, as opposed to a really wide cleft. And even then, there's some of those that look great, and some look like hell. So one of the things that we ought to factor in is the severity of the initial cleft. I haven't found a convincing study that has linked outcomes to the severity of the initial cleft. Now, you could argue that doing an effective NAM kind of negates that. But even there, I would say, let's see. Let's see the long-term results. And does it in fact negate it? Are there other things that you could do that are going to get you close or as good, especially over the long term? I know that having read this now and participated in this podcast, the patient that I'm doing on Monday might just get a piece of cartilage on the top of his dome on the cleft side. I'm not sure, but it's possible.
Well, I think that, if nothing else, says it all about this article. I think this has been a great discussion. We've gone from rhinoplasty technique to how we report our outcomes in craniofacial surgery. So I think with that, we'll end the discussion on this article. Remember to tune in to the other 2 articles that will be discussed on this month's podcast, as well as the PRS Journal Club podcasts that are broadcasted every month. Also, don't forget to participate in our monthly Twitter, #PRS Journal Club, where we'll be able to interact directly with this month's selected articles' authors. And thanks again, Dr. Mackay, for joining us.
Thank you.